Here's our quadricep tendon up here. There's the patellar ligament on the bottom. All right. Now, this thing shows a really good thing that you don't ever see. It's this ligament right here and right there. That's the lateral and medial retinacular ligaments that come off of the patellar complex there. A lot of people have a problem with the patella. When you bend your knee, should track right here in the middle. So if you bend your knee, it should track. It should move up and down in that groove perfectly in the middle. A lot of people, though, it won't be in the middle. Instead, it rubs up over the condyle, and it causes pain. It's called femoral patellar syndrome. And it's typically due to a lateral retinaculum that's tighter than its medial counterpart. So it pulls the patella laterally. So if that's your problem, then the way to fix that is arthroscopically. They will go in there with a scope and a pair of scissors, and just open the scissors up and just slide it up that lateral retinaculum. They cut it. And so it releases the patella to track in the middle. The medial is not strong enough to pull it to the medial side. This is called a lateral retinacular release, or patellar-femoral syndrome, femoral patella, whatever you want to say. Lateral retinacular release. That's what they're cutting. The knee space here is, of course, you've got a synovial membrane that secretes a couple of milliliters of really viscous fluid. When I open up the knee this afternoon, well, you can open it. Have you opened a knee before? It's really easy. all you do is, you do it. You can do it. Somebody get up under the knee and pull up, and you take a scalpel and just start cutting through the front. So you're going to cut through the ligament here, and then you'll wind up cutting through the synovial membrane. And as you cut, you'll feel it freeing up, and just have the person below keep lifting the knee. And once you get it all the way open, it will stay open, and you're looking inside the knee. Put your finger on the synovial fluid, and it's like mucusy, thin mucus. Okay? You do it. I'm not going to do it. You do it. After you've dissected the thigh, you do it. On one knee, not both. The knee, so you've got the synovial cavity, synovial space. You also have around the knee several bursa, like this. These fluid-filled sacs are up underneath the quadriceps tendon. They're all over the place. The thing about the knee, though, is like the shoulder, the bursa communicate with the knee joint. So if you want to, if you need to tap a knee joint, you don't actually have to stick the needle in the knee joint itself. You can actually stick the needle up here just below the patella, right there. If it's a nice swollen knee, you can actually get the fluid from the bursa, which is the same as the fluid from the knee joint. Now, it's easy actually to stick a needle in the knee joint. It's really easy. But if you don't want to go into the knee joint, you can go into the suprapatellar bursa. That's not what it's called. What is that called? Yeah, I think it is. Yeah, it is. Suprapatellar bursa. Ooh, I remember that from way back. Okay? There's another bursa, though, that you need to be aware of, and that is the bursa that sits between the patella and the quadriceps tendon. That is a subcutaneous pre-patellar bursa. You don't need to say subcutaneous. It's pre-patellar bursa. The reason that you need to know about that bursa is that when you get somebody coming into the office with a knee that looks like that, and it really hurts, I want you to drain my knee, you gotta know, is it in the joint or is it in the prepatellar bursa? This happens to be in the prepatellar bursa. It's called housemaid's knee. It's just an inflammatory process. You stick a needle in it just like you would an olecranon bursa, easy to drain. You can see it right here, filling this big space, real easy to drain. But you want to make sure that you're dealing with a prepatellar bursitis and not a suprapatellar bursitis. If the fluid is in the knee, you're going to be able to squeeze it from, first of all, it won't be sitting right over the kneecap. It'll be extending up here. You can squeeze the fluid from above the knee to below the knee to around the knee. You can actually take the patella and you can feel the patella bone if the fluid is in the synovial space or in the suprapatellar bursa. You can feel the bone. In housemaid's knee, you can't feel the bone so well because it's got a pillow of fluid sitting on top of it. So you need to make that call before you go stick a needle in there. There are 4 ligaments and 2 cartilages in the knee. You have a medial and lateral cruciate that support the knee as far as a varus and valgus strain. Valgus strain is when you take your leg and you move your foot laterally. You like make it in the shape of an L. You understand that the valgus strain puts stretch on the medial collateral ligament. Varus, V-A-R-U-S, strain puts pressure on the lateral collateral ligament.
What's that word? Not.
Valgus, V-A-L-G-U-S, and varus, V-A-R-U-S.
What's medial varus?
If it's, think of an L shape, that's how I always remember it. You know, L shape like that, that's valgus. Varus is like you would take the plantar surfaces of your feet and put them together. So bow leg would be varus deformity, knock-kneed would be a valgus deformity. It would.
What was that again?
What was that again? How do you want to say?
Valgus deformity is knock-kneed. Bow leg deformity is varus deformity. Okay? Inside, now these are outside the joint. Inside the joint, and you have very few ligaments that are actually inside a joint. Matter of fact, you don't have any except for these, I think, that I can remember. You have an anterior and a posterior cruciate that are in the shape of an X with it directed this way. The X is directed this way. The anterior and posterior cruciates are named for their tibial origins. So this is the anterior cruciate, it's anterior to the posterior cruciate. And then finally you have a medial and lateral meniscus. These are cartilages that won't show up on an X-ray. They will show up on an MRI, but not an X-ray. There's one thing you need to keep in mind, and that is the medial collateral ligament is attached to the medial meniscus out here medially, most medially. The lateral collateral ligament is not attached to the lateral meniscus. Only the medial. Yeah, this will make sense to you in just a minute. Give me a minute, okay?
So the medial is just connected to both?
The medial collateral ligament You can also call this the tibial collateral and the fibular collateral, it doesn't matter. The fibula is lateral in your leg, right? So the medial collateral ligament is attached to the medial meniscus. So if you were to draw it, here's the meniscus, the medial meniscus, it's attached. The lateral meniscus, it's not attached. This has anatomical importance here in just a minute. Again, this one's going to be anterior cruciate ligament, and that's the posterior cruciate right there. Now here's the here are the cruciates. This is what I want you to imagine. If we cut that anterior cruciate here, right? The anterior cruciate is preventing the tibia from going further anteriorly. It won't let the tibia go that far. The posterior cruciate won't let the ligament, won't let the tibia go backwards. Everybody follow that? Okay. These are the menisci right here. They're these little cups. They're not circles, but they're sort of lunate shaped like the acetabulum, with the opening directed medially. They come to a fine edge here. They're thickest laterally. You'll see them in lab this afternoon. They're not as impressive as the amount of pathology or symptoms they can cause a person if there's a problem with the menisci. And what their function is just like the glenoid labrum up here. They deepen the articular surface. So the condyles of the femur have something to glide in. Keeping in mind, if we go back to this slide right here, all the way back to the beginning, that what you have on the articular surfaces here, a bone, is cartilage. You don't have bone on bone. It's cartilage on cartilage. Cartilage is, you know the gristle when you bite into a piece of chicken and it's like squishy, and you can't bite through it, but it's squishy? That's what this is like. That's cushiony. Bone on bone hurts. All right. There are different, when you go to work for an orthopedic surgeon, these things have about 50 different parts to them. Each of the little pieces is named. I've never learned them. I don't care what they are. It's a medial or lateral meniscus, all I care. Okay? This is what they look like arthroscopically. This is a lax anterior cruciate ligament. Here's a tear in a meniscus right here. There are different types of tears. Here, the interesting one is this right here, the bucket handle tear, which is on the inner side, and it's a longitudinal tear. The reason they call it a bucket handle is that the inner piece can flip over like a bucket handle, and it can lock your knee. I had a patient came in one time, her knee was just locked like that. Could not get it to move. And you got her supine, you try to force her knee, it hurt like hell, but it wouldn't go. It was because of that bucket handle, and it wasn't. I got her down there to x-ray her, and I flexed her knee and allowed the handle to flip back over, and she was fine. Sent her home. Didn't do anything. So she's going to have arthroscopic surgery. What they'll do is go in there and cut the bucket handle out and trim this back so that it becomes a nice smooth edge. So the other thing, I don't think I have a slide, but while we're at it here, since we're talking about arthroscopy, is a lot of people have joint pain, in walking, and it's due to there's cartilage on the back of the patella that rubs in that patellar groove. As you get older, that cartilage wears away and you start getting bone on bone, or it gets just ratty looking, the surgeons, if this is the patella, the surgeons have a thing that they stick in there like this with a little blade that's inside, it's a rotating blade inside of a little housing like that. And it's like a shaving thing, you know, you could go zzz, shave your whiskers with it. What they do is they go in there and they're looking through the scope with another hole, and they just shave the back of the, that roughness off the back of the patella, and that's all it takes to be happy forever, okay? It happens a lot. So if they're gonna go in here to fix a tear, they'll usually go ahead and shave the back of the patella and, kind of clean up the area. This is the Baker's cyst that I mentioned earlier. You see that fullness in the back of the knee. You see these these are really frequent. You probably run into about one a month in primary care. They're really frequent. All right. So here are the anterior and posterior cruciate ligaments right here. Now this is what I want to show you. Let me get somebody on the, can I get you up here on the, can we slide this down? It'll lie down up here. Might need to move it down a little bit. All right, your feet straight. All right, so what you're going to do, can I lift this up? All right, so I'll do this. So what you're going to do is the Lachman's test. You don't have any knee problems, do you? Okay, so what we're going to do is we're going to test the competency of these ligaments and the meniscus. All right, let me roll the other one up as well. All right, so Lachman's test here is what we're going to do is going to bend the knee and put her foot right here. Now, if somebody tells you to sit on their foot to stabilize it, do not sit on somebody's foot. Okay, then when you get in phys die, they might tell you to sit on their foot. Don't sit on it. I don't want your ass on my foot if I come to see you, okay? Just put your hand on it like that. Then what you want to do is get your arm up underneath the leg here and pull it towards you. So come here, Annie. I want you to see this. I want you to watch right there. I'll try this. See, I'm able to pull her leg forward just to like maybe less than a half a centimeter, right? She's got a pretty tight anterior cruciate because the anterior cruciate prevents her tibia from coming forward, right? And I want to compare it side to side. The other thing I want to do is take and push downward to see if I can push her backwards. That's testing the competency of the posterior cruciate. You can't live with a torn ACL. You can function with a torn PCL. A lot of times they don't even repair them. All right, now, understand this. If you had a torn ACL and you were under general anesthesia where you couldn't feel this, and I did this one time, you can take the lower leg, pull it out, and pull it up so that it's actually even with the top of the thigh. Remember, that's the ACL keeping you from doing that. This was in the OR, so she didn't, it was an attorney, so that's fine. You can do the stuff like that to an attorney. So that's Lachman's test. Anterior posterior drawer, same thing. Now the next thing we want to do is we want to test the competency. Oh, you can sit there, I'm sorry. Yeah. The next thing we want to do is we want to test the competency of the collaterals and whether or not the menisci are smooth. And what we're going to do here, and I think it might be on the next slide. Yeah. This is McMurray test. What we're going to do, and you have to. All right, so what we're going to do is I'm going to say, I'm going to flex your knee, okay? Flex your knee. And now what I'm gonna do is I'm gonna turn her foot inward, and I'm gonna take her knee outward, like that. And now I'm gonna straighten, as I straighten her knee, what I'm doing is I'm putting stretch on this collateral, excuse me, I'm sorry, I'm putting stretch on this collateral, see, because I've got her leg like that, and I'm squishing the medial meniscus. You see what I mean? I'm squishing the medial meniscus, I'm stretching the lateral collateral. Now, what I'm gonna do is I'm gonna do it so it binds your knee. So I'm gonna push you in, I'm gonna turn it like this, and you see that? As I straighten it out, I mean, you got some good stretch going on there. I got tension on your lateral collateral. If you had lateral collateral damage, it'll light you up right now. Or if you had a meniscal tear, that would light you up. Now what I'm gonna do is do the exact opposite. Bend your knee back, turn your foot outward, push your knee inward, and I'm gonna stretch it again, straighten it out again, and now I'm hold it right there. I'm stretching the medial collateral and squishing the lateral meniscus and go all the way down, right? No pain. Third thing I'm gonna do is I'm gonna go back up again. I'm gonna grab her patella and I'm gonna pull it laterally as I lower her leg. If she had a patellar tracking problem, I'm making the lateral retinaculum worse by pulling her patella laterally. So if she came in with knee pain, this is what I would do. The final thing is, can I get you to roll over on your belly?
Wait, what's that last one that you're doing?
The lateral retinaculum.
What's it show?
That's just patellar tracking.
So it show if the lateral retinaculum is.
Yeah, that would show that you have patellar femoral syndrome. The last thing I'm going to do is the Apley test here. So if this is the knee, the bad knee, what I'm going to do is I'm going to bend her knee, and I'm going to say, all right, let me know if this hurts. I'm going to put all my weight on her foot, so I'm squishing the tibia down onto the condyles, and I'm going to rotate it back and forth like that. Does that hurt? Let me do it harder. Okay? So what you're doing is you're squishing the menisci into the condyles. If you had a meniscal tear or something like that, again, it would light her up. Okay? You can sit up. That's good. Yeah. Okay, thank you, ma'am. So, anterior posterior joint spine, Apley, McMurray, these are all tests you're going to do all day long when you're in primary care. Here's the, right here is, when I'm talking about this medial meniscus attachment to the medial collateral, this is the reason it's now the unhappy triad. This guy, this is known in football as a clip, where this guy's foot is planted, I can't see it, this guy's foot is planted and he's being hit from behind and laterally. So his foot is planted and his tibia is being driven forwards, like that. What that's going to do is it's going to pop the ACL because it's going to drive his tibia beyond the ACL. Because it's putting strain on the medial collateral, it'll rip the medial collateral, and because the medial collateral is attached to the medial meniscus, it'll rip the medial meniscus. This is called the unhappy triad. This is why you do not clip in football. This is Australian rules football. They clip there. There are no rules in Australian rules football. You guys ever watch this? This is the most barbaric sport ever. It's like full contact football and no pads. It is insane. All right. This guy right here happened to lose his lateral collateral ligament, therefore his knee is not, his tibia is no longer underneath his femur as it should be.
That feels good.
Okay? And this guy over here, this wussy guy right here, you see he putting a little strain on the medial, lateral, collateral ligament. Don't do that. Get after it. Rotate their foot and push their knee down and straighten it out. Really get after it, straightening it, okay? Anybody in here have a torn collateral? If you did, I mean, it would be impressive how much we could move it. Okay. Here's a normal knee over here, nice crisp lines, nice symmetric space across there. Here's osteoarthritis that I was mentioning earlier, narrow joint space, feathering, junky looking. This is an anteriorly dislocated knee. That thing is supposed to be down here. This is again, like a hip. It takes a lot of trauma to dislocate a knee. I don't think I've ever actually seen a dislocated knee. So they're pretty rare.
So would that ACL be torn, that dislocation?
Oh, yeah.
Yeah.
Oh, yeah. Among other things, yeah.
It says that it's a threat to blood vessels, is that just like the popliteal artery?
Yes, popliteal, it says a threat to blood vessels and nerve, yes, popliteal. You always want to make sure when you're dealing with a dislocated joint that you have downstream capillary refill pulses. It's warm to touch. It pinks up, you know, the capillary refill is less than 2 seconds. If it's not, you got a medical emergency on your hand. You would have to reduce this in the field or as quickly as you can. Pulled hamstrings are just stretches at the sites of origin of the hamstrings off of the, you always see them grab up here, right? That's because they're grabbing the ischial tuberosity where the hamstrings originate. Quadriceps strain, remember that the point here is that you strain muscles, you sprain ligaments. I think at some point I said that earlier in this course. The veins, we talked about thrombosis, and I don't think we really need to talk a whole lot about it, more about it. Understand though that in the superficial veins of the lower extremity, you have valves. So when if he comes over today, when Chad comes over today, he wants to look at the veins because he harvests the veins. So if you've got the great saphenous vein here, it has valves in it along the way. If he's going to put that in the heart, he's got to make sure that he turns the vein upside down to suture it in so that the blood can flow backwards through the valves.
Oh.
If you suture it in like you took it out, you got a dead patient. Not a good thing. You understand what I mean? Never thought about that, did you? Ha-ha! You got so if you take the vein out, and it's like, crap, I forgot which end was up. What would you do? Just put it in, go. If you blow with the valves, you can. Can you imagine how pissed off a surgeon would be if you broke sterile field? Oh crap, I forgot which end's up.
Just wondering why you put it in your mouth.
Iliotibial band syndrome I talked about yesterday. We don't need to go into that any further. Osteosarcoma, this is the worst malignancy of bone there is because it usually affects teenagers. And it usually affects either the proximal tibia or the distal femur. Most of the time it's the distal femur right here. And it metastasizes. The first treatment for this is amputation. Period. Amputation. You start with amputation, and then you consider what you're going to do. It's the last area is it hits the shoulder for some reason. For some reason, it picks those three sites. 99% of the time, it'll be one of those three. Most often, it's the knee. Here's an example of one that's obviously going to be metastasized already. This is what they look like on an X-ray. Anybody comes in with bone pain of the knee, always x-ray it. Especially if they're a young person, always x-ray it. You just never want to miss this. And by the way, I would tell you that always x-ray it, always x-ray things, even if you think it's not gonna be anything. You know, if somebody comes in, I got a pain here, x-ray it, because you just don't wanna miss stuff, and that's always not a good thing. Anything else we need to talk about?
For that need, why have they not taken care of that yet? Because it's pretty big, but they have.
I would imagine this is not in the United States. I don't know where this would have been. You know, it's like that guy with the ear.
Yeah.
You know, why was this not taken care of? That was here in Oklahoma.